Hi everyone. We've been running groups for about 6, 7 years now. We started off with diabetes. We were hindered a little bit by the pandemic, and then picked them up again face to face, particularly after the pandemic. We now run diabetes, hypertension, COPD. A new group, specifically for people with newly diagnosed diabetes, and we're just about to launch our menopause clinics. Next slide, thanks. Oh, next one again. Let's move on. I'm going to run through quickly about what we did last year and how we've tweaked it this year. Last summer, we always had the plan to do a group, but life gets busy, and I spent all summer doing all the children's asthma reviews over the summer, and we still had all the COPD reviews to tackle. So if anyone else that can see these sort of numbers and can relate to them, it's quite daunting at the beginning of winter. This year, we're aware of it much earlier, and we've decided to tackle it in June. Excuse me. So last July, we got to end of July, thought, right, we better sort out these COPD groups now. And unfortunately, it was getting into sort of September, October time before we managed to do it. But we did launch them all within a month of planning it. This year, we've learned from that, and we're doing our first group on Thursday with the plan to review the process, because we haven't been doing it for a few months, and then we're going to launch them all in August. So we're hoping to see all our COPD patients before the winter pressures really start taking effect. There's often a lot of questions about quality of care and person-centred care. But personally, I find 20 minutes for a COPD review or a diabetic review, it really is about what I need to achieve. I need to tick all those cough boxes. I need to try and stick to time because I want to leave at the end of the day. But I'm doing back-to-back appointments, whereas with a group, I get a far more meaningful discussion. It allows patients to address what they want to know. One-to-one, as I said, is clinically led, so the patients get a chance in a group to really say, this is what I want to know about my condition, this is what I need to know to keep well. And a group allows time for patients to reflect on the answers we're providing, rather than trying to remember them all in those 20 minutes and take it away, and then they come up with problems afterwards. I find that the one-to-one method works fine for traditional sort of motivated patients that come in, know where they are, they can look after themselves, and they just need to check in. But for those people that are really struggling to make changes, groups are much better, and especially your quiet patients that don't really want to speak up an awful lot, they can sit quite quiet in a one-to-one. You're talking to them a lot, you don't necessarily get a lot back, whereas in a group they can listen to the questions other people are asking, they can listen to the answers, and they've got a lot more time to reflect and come up with ideas. Next slide, thanks. So now at Moatfield, we've now got 4 facilitators. They also do our recall team, so they really can tie in who needs to come in for a review and when. They understand the process, but then they get some patient time as well, patient-facing time, and they will be our coordinators and our facilitators. The thing that's held us up for COPD was the stairs. Our meeting room's upstairs, so we're actually building a room. Should be done in September. That's going to be on our ground floor. Going to be capacity for wheelchair users, and particularly with COPD, people couldn't get up the stairs. So last year we picked a date. We hired the town hall with the plan of doing 3 groups a day, back to back. When you do the training with ELC, you get the session planner, you get all the materials to work through this, and that's what we used. We started off with our session planner and worked through each stage what would be the problems. And the biggest issue we had for COPD was people don't like lots and lots of text, or particularly with this group. So we decided to do a results board where we would get them information as they turned up. So we trained our facilitators, but actually we ran the group, as Georgina said, we changed it slightly, and we had me as the clinician, but we actually had an experienced HCA in there at the beginning as well as the facilitator. So as people were coming in, they were signing their consent forms to share information, they were checking their oxygen levels, the HCA was helping them fill out data on MRC scores, CAT scores. And then we were transferring that to the board. And the facilitator the whole time was keeping us on time for the session flow. We confirmed everyone would get one-to-one, and we had a big box of all the different inhalers, inhaler check devices out. And on our results board, we put down the medication people are on, so they could see that actually there's a vast range of inhalers and medication plans available to everyone. So as the board got populated, the HC would then lead, and the facilitator then stepped in and started running through what sort of questions did people want to know, what did they, what had sparked their interest looking at the results board. They then kept me to time. We had a really good discussion about inhalers. Smoking was the really big winner. I've never smoked, and for anyone that's done COPD reviews, trying to talk to people about smoking cessation can be really quite hard. In a COPD group, it's great. The patients that have given up smoking already just do it for you. They were really quite direct. They're quite blunt. In diabetes groups, they're quite blunt about how you can improve your weight and make dietary changes. So they're doing an awful lot of work for you. And then I went around doing the one-to-one at the end. So the one-to-one, by then, they'd already looked through the different inhalers. Some patients have got inhalers out of their bags. They've demonstrated them. And people had already decided, actually, I want that better inhaler. I want to change this. Or maybe I should just be taking my inhaler more. Maybe I should be using my blue inhaler differently. Smoking was a big one. So it really made a difference to our clinical outcomes and the patient's enthusiasm. Next slide, please. What we do is we make sure the whole team in surgery understands the process. So patient services team, our workflow team, all new staff observe a clinic so they understand the process. What we did find is not all groups are attended equally. So as Georgina said about the numbers, our hypertension groups are really well attended. Our diabetes groups are fairly well attended, but our COPD groups, we made some assumptions and we realised that some people would just be having a bad day. So we really book extra numbers in there. So we do expect maybe 4 or 5 people to not turn up, and therefore we will invite maybe 16, 17 people. But remembering, even if people don't attend, you haven't then got a clinician sitting there with an empty appointment or wasted appointments. So if you've not got 1 or 2 people attending, you're still seeing 7 to 12 people, depending on the group and how you run it. Before the group, I always check with facilitators, so we will think about anyone that's maybe got low literacy, mental health issues, anyone that's a high risk. We'll look about questions that I might really want to raise. So smoking's an issue and no one's raised it. The facilitator might ask if anyone right at the beginning wants to know more about giving up smoking or how to lose weight or improve their HbA1c. We always get patient feedback and we do act on it and we change things. And the COPD group is definitely the one we changed most. We made assumptions that people wanted their invite by letter rather than a text reminder. So lots of tweaks we made there. We use the improvement planner, look at what went well, what can we improve. And what I've learned is, even though the diabetes groups, we've been doing them for 6, 7 years, we really need to keep looking at that. And it's really good for people that are new to groups as well. So our facilitators can learn from it. We can learn on how we're working together and keep tweaking things and improving it. And as Georgina said, we're now building a room on the ground floor so we can really expand the range and frequency of groups we can deliver. Some people, it's not appropriate for a group, so there's not the assumption that everyone will go for a group, but that is our first line choice. But there will be still some people with mental health issues or really intricate health issues where you might still want to see them one-to-one. So our aim is to encourage everyone, the majority, into groups. Next slide, please. So I think we've talked a lot about patients, but there's also staff satisfaction. So I can have 1 hour of really interactive discussion with patients. You're in partnership with them. You have a much better relationship with them rather than 10 back-to-back repetitive discussions. And I find out what patients really want to know. It's really interesting that in the COPD groups, everyone, the first question was, what's an exacerbation? And yet we're asking people to report on how many they've had each year. And I know I've talked to these people about it in the past, but having that time to sit back and listen to the answers, we're really hoping this year they've really understood it. And our exacerbation rate, the reporting rate, does seem to be at the moment slightly lower. But patient satisfaction as well. They're supporting each other. They're not alone in this. They understand there's other people living with this. They definitely answer each other's questions. So some groups, actually the clinician during the discussion really doesn't need to say an awful lot. They might just want to correct things. And as I said, the smokers and weight loss really makes a difference. So it's really think about staff motivation and education. We really learn a lot from them. So if you've got new staff that are starting to take up reviews, they can learn an awful lot in this session as well. Next slide, please. As I said, first question, every single group we ran was, what's an exacerbation and when should I use my steroids and antibiotics? Now, if you think we're all trying to reduce the amount of antibiotic packs that people are having, we really optimised our medication. So 10 people for a 20-minute appointment would take me 3.5 hours roughly. With groups, I can prep, consult and document much quicker than that. Our facilitator will be making notes of everything I've discussed, and actually they put that in the notes now as well. So I only really have to do the one-to-one documentation. We've really significantly reduced our MDI prescriptions. So patients really understand that we're trying to optimise their inhaler for their good, not just because we think that's our opinion and that's our favourite inhaler. But importantly, the spacer use went up as well. So those people that do need an MDI, we're using a spacer. Next slide, please. So what have we done this year? We haven't done groups now since November for diabetes. So we did them all last year. We parked it for a little while. So this year we've got out the session improvement planners that we looked through last year. We've tweaked our template for documentation. We've tweaked our results boards and how we're going to document it. So we've looked on that. So we're going to do a group on Thursday with a group of patients. Again, we've invited 14 patients, hoping that we will get 10. And then we will look at our session improvement planner afterwards, and we're putting our dates on for our groups. So we're going to start booking our groups much earlier this year. We're hoping to do end of August rather than running into the winter. And we're also starting to tweak our appointment screens. So we're going to put our group clinics up on the appointment boards for PST to use 12 weeks in advance. But actually, we're not going to be adding our one-to-one invites appointments quite so quickly. So you've got more flexibility to use your one-to-ones for the patients you need to book in at short notice, or that you really need to see, rather than being booked up with lots of annual reviews. So groups are really enjoyable. They take a lot of the effort from the team. They're really rewarding in time and quality of care for patients, and patients are really enjoying it. There will be some that don't want to come to a group, but the vast majority really appreciate that discussion and that peer-to-peer discussion, and also understand that they're the experts in their care rather than relying on us making all the decisions.
I've got a question, Laura, which you might like to cover quickly. So Caroline's asked, what do you cover in the one-to-one part of the session? So maybe you could just say, like for COPD, for the COPD groups, what are the sort of typical things that you save and discuss in the one-to-one?
Actually very little, because usually during the group discussion they've made decisions about what they want to do and taking it forward. So they might have decided they want to change their inhaler, they might have decided yes they're going to have their pneumonia vaccine, or they'd like some support with smoking cessation. So really that one-to-one, it's okay, you'll always have those ideas, just like you would a one-to-one appointment. You've got an eyeball of that patient and you know what you might be thinking. When you get to that one-to-one, they've often made their decision. So you'll be changing an inhaler, making referrals, pulmonary rehab referrals. In diabetes, a lot of the time it's coaching referrals or tweaking medication. So that's very specific stuff that a patient might need. But a lot of the time they've already decided what it is they need. And it's just that discussion about, yes, that's appropriate, or can we tweak it? And when would you like a review? Are you happy for 6-month review, an annual review? So it's that negotiation.
So Pat has also asked as a little supplementary, how much time does that take? So it does depend a little bit, doesn't it? But we usually say that the whole clinical session, you can expect it to be at least 30 minutes, but if say you've got 10 patients, you would probably say 5 minutes per patient on average. Do you know what I mean? So the whole clinical session takes around about half an hour to 45, 50 minutes. Does that fit for what you've experienced, Laura?
Yeah, I think as you get more experience about running the sessions, the group discussion becomes a little bit longer and the one-to-ones become shorter. But I think, as you said right at the beginning, you need to give yourself the time to really make it work. So don't think about time savings at the beginning. Think about quality and all those other things you're trying to achieve, because the time savings will definitely come right at the start, but the bigger time savings will come with experience and confidence. So I now find that the group discussion is probably at least 3/4 of the time of my clinical time, and the one-to-ones are much quicker.
Yeah,
and the care
that's
plans
interesting.
we often, sorry, the care plans, especially for COPD, will often get the patients to write it while they're there. So you're not having to write out lots of care plans and send it out as well. They're filling it out. They're making notes as you go along.
Yeah, interesting on the care plan thing that we've got a team who've completely just do all of their asthma reviews now as group clinics, and they've saved as much nurse time because the nurses no longer have to write all the care plans out afterwards as they have the group clinic element. So it's really interesting. I can see questions from other questions coming up in the chat. I'm going to leave those to the end because it will be interesting to hear from both Rupert and Laura on those two questions that are in the chat. So and guys, you might want to pop some answers in the chat as well. Laura, your thoughts on those two questions once I hand over to Rupert. Are we there? Shall we hand over to Rupert now? Have you just got a little bit more to go?
I was just going to say I'll answer the questions, or I might have to catch up with you later because I've got to head off to another teaching session in a second. But if there's anything afterwards, I can feed back. If that's all right, Georgina.
Yeah, that's fine. So I think we've covered it anyway, haven't we? Your key learnings. So that's brilliant. So yeah, do pop your responses to those two questions in the chat and we'll hand over to Rupert. Rupert, over to you.
Thanks, Georgina. And I think Laura's done such a beautiful job of helping us to imagine what it's actually like if you're in the room. And I hope to add to that. So my name's Rupa Joshi and I work at Woodley Centre Surgery, which is in Berkshire West. And I'm also transformation lead for British Society of Lifestyle Medicine. So we do a lot of group clinic promotion there. And for those of you, I've seen in the chat that there's a few of you from the Southwest. So I've recently started working in the Southwest as Deputy Medical Director for Primary Care. So I would love to connect with anybody from the Southwest if you want to do more and understand more about group clinics. Just my email address is really easy. It's just my name at nhs.net. So and I'll pop it in the chat as well. So what did we do? So before the pandemic, we were doing paediatric face-to-face group clinics. And at the moment, the group clinics that we're doing menopause every other Wednesday evening as a menopause evening, and that's across the PCN. We're doing postnatals once every quarter. So all the babies that are born across the PCN within the last 3 months, the parents and the babies come as well. We do face-to-face and virtually. It depends on what the group want. We ask them in advance. And we're also doing hypertension and lipids, which is working really well because what we do is one of the questions on the recall is we have the QOF recall system in place to get people to have their blood pressure and their lipids done. And then what we do is we give, when they're having their bloods or when they're having their recall, they have a little leaflet that's sent by Accurx that tells them about the group clinic. So they've already got that in mind. So they know that for their follow-up, if they need follow-up, they'll be asked to come to the group clinic. And that all gets sent as a task And the patients also have the email address. So we have a dedicated inbox for group clinics. So they then email the group clinic inbox, and then they get added in. And as Laura showed earlier, we've got slots with direct booking, which is a really, really good way of minimizing the admin. So you would text the patient back saying, we would like to see you for follow-up for your blood pressure or your lipids or whatever they're having. Here is the direct link to book. And that is a game changer, really, because it does cut out a lot of admin. So going back to the asthma. So what we did for the face-to-faces was we did 4 to 6 year olds, 6 to 8 year olds, 8 to 10 year olds. And then during the pandemic, we really wanted to keep people safe. And we wanted to make sure that people, that the kids and the families knew how to optimize the asthma treatment, when to call the doctor, and when to be worried, what are you looking for, when do you know it's COVID, and when do you know it's just an asthma exacerbation. So we did all of that and we reached out virtually, and that was to all the adolescents. So we did 11 to 18 year olds, which was great because by that point they were all doing online schooling. So they all had their headphones, they were all writing in the chat, they knew what they were doing. It wasn't like when you have the adults on and you have to explain quite a few times how to get onto the Teams and that kind of thing. They were straight in there and really understanding it pretty well. Next slide, please. Oh, I think I've taken control. That's right. So what we had a look at our data, and what we realized was that there was a lot of children presenting coughs, colds, asthma, going to A&E, calling 111, going to out of hours GPs. And it seemed, even though a lot of them were coming for their asthma reviews, it kind of seemed like they didn't quite get it. And a lot of them were just not even bothering to come to their asthma review. So we had a massive DNA rate, and people weren't, booking in for asthma reviews. So we thought the best thing is to look at the school year, and we got them in just before they went back to school, either the end of August or the very beginning of September. And it was that kind of time where we decided to stagger the group clinics. And we made them really accessible. So when we did our face-to-faces with the little children, we had things like pom bears and calypso drinks, and I brought all the toys because my children had grown up a little bit. So we had snakes and ladders. We had lots of little games at the back of the room, and one of the team went on the CBeebies website and printed off colouring sheets, and we had all felt tips, and it was lovely actually, just watching them all play together. Children that never met, and you know what children are like, they just make friends really easily. And then the adults would look at the children and think, the same, and they made friends with each other. And the first group that we did, actually, the parents all made a little WhatsApp group and kept in touch with each other afterwards. And they asked questions that you wouldn't normally ask in a group clinic, like, if it's a cold day, should I put the zip up, and should I put a scarf on to stop his neck getting cold? And if he's got a cold, should little Johnny go swimming? Really practical questions that patients never really ask because they never feel safe. They never feel, it's all medicalized, isn't it? And this way it's more like a chat with other parents. And Laura is absolutely right. What you really want to do is take a step back and let the parents answer each other's questions. Because if a parent is answering a question, they then think, actually, I do understand this because I feel empowered. I know how to answer other people's questions. And then that self-efficacy comes in because they feel more confident about being able to look after themselves and their children better because they can answer other people's questions. And with the data that, how do you choose who to come in? You don't want to waste all your efforts on people that don't necessarily need to be there. You want to really target your efforts into those children that are bouncing in and out of A&E. So we did our searches based on attendances to A&E in the last 6 months or hospital admissions. Those children that have had more than 8 Ventolin inhalers. At this time, you were supposed to give them one for school, one for home. So they were on more. Now the guidelines have changed and they're supposed to carry them around with them, aren't they? So 3 courses of steroids in the last 6 months, overuse of inhalers. So all of these were popping up on the cough boxes. So we said, okay, let's target those that really, really need it. And in the invitation, we were specific of why you've been invited. We noticed that your child had more than 3 attendances out of hours. We noticed that you'd called 111 a few times last year. So it was really targeted. So the parents knew this is actually really important to attend because, we don't want to go through the same thing again this summer and this winter. And in our evaluation, we actually looked at the last year's worth of attendances and admissions and salbutamol inhalers, GP attendances. And then we went through and did that over the year. So a year later, we had our data to say what happened in the winter before you had the group clinic and this one-off intervention of a group clinic. What happened in the following winter? What did it make a difference from year to year? And reminding people about their flu nasal sprays, reminding people to keep well. And we also printed out the asthma UK care plans. So the parents were actually filling them in. And as the kids got older, the kids were starting to fill them in. So what's 70% of your normal peak flow? What's 50% of your normal peak flow? And it's that real understanding that when you're red, green and amber, when you're green and you go to red, there's actually that area in between, the amber, where you can actually do something about it. You can stop yourself going into A&E, getting ill, by doing things with your inhalers, by doubling your preventers, by using more of your salbutamol and using your peak flow to really monitor where you are. And I think that was a bit of a light bulb moment for some of the parents because they didn't realise that there was an amber stage and that they can actually do something about it. And I think that in itself was huge for helping them not be unwell for the following winter. So the group clinic was a similar setup. We did an icebreaker welcome. We did questions and answers, and they all wrote them on post-it notes. And then we themed them and had a general discussion about general questions that the parents were wanting to ask. And we got them, and on their way in, we got them to weigh themselves and did their height and weights. Our nurse did those on the way in, and our facilitator helped. And then we did the consent forms. We taught them through the asthma care plans. We watched them doing peak flows for those that were old enough. And we also watched their inhaler technique. So they all did it and we were watching them and guiding them on how to do it. Our pharmacist was in as the clinician as well as myself. And this was really because we were starting it off. So it was more staff heavy. As we became more used to it and I felt that I trained the pharmacist enough and the nurse enough, then I stepped back and let them get on with it. So it was time efficient and clinician efficient. And then we did the one-to-ones with the results board. And we said, this is your peak flow, this is your asthma, your inhaler technique, try and do it a bit more like this. This is what you need to be looking for an exacerbation. And so it was very personalised to the patient in the one-to-ones. And we really went through the QOFs and the patients had a questionnaire and they did the 3 questions. Are you sleeping at night? Does it affect you during exercise? All of those were tied into the asthma results board. And these are the questions. And we also asked about smoking at home, pets at home, and the questionnaires were all put on the results board as well. As they came in, our facilitator was writing it all up. So when I did the one-to-ones, it was pretty obvious that people needed to increase their inhalers or the doses of the inhalers, because not forgetting that, children grow quickly. So if they've got the 50 micrograms, they might need increasing to the 100 micrograms. And what did the questionnaires tell us? So the majority of these children that were the brittle asthmas that we invited in were having asthma symptoms, were having chest tightness, were finding it difficult at night and having coughs. were finding it difficult to exercise. As much as 50% were experiencing daily interferences with their symptoms. And what about the impact? So as I said earlier, we compared one winter with the following winter. So we did have small numbers, but the average use of Ventolin inhaler from winter 1 to winter 2 fell from 18 to 8. The recorded hospital admissions from 12 hospital admissions, which is amazing, to go to 0 the next year from having one group clinic is remarkable. And if we think about how, if we scaled that up to having asthma group consultations, we could be reducing attendances and the GP attendances they don't come to you when they're well, do they? They only come to you when they've got a cold and they're struggling. And so none of that high intervention group came back the next year because they were all self-managing. They knew how to manage their asthma. And they knew how to do peak flows. They knew how to monitor the amber status to switch it back to red rather than switch it back to green rather than go back to red. And we had excellent feedback from the group. We also did the evaluations and things like that from our online group. And we also did an adult group. And like Laura said, we did a COPD group as well. And this was kind of really targeting those that really needed it over COVID. So I'll go to questions. And I wasn't looking actually to see if there are any more questions in the chat.
So we'll take a quick question. We've got one that's just popped into the chat. How many children are in the session with their parents present? Can this be led by a COPD nurse specialist? We are quite short on time, Rupa. So if anyone else has got any questions, please pop them into the chat because I will have to start to bring the session to a close. But it's been amazing and such fantastic stories. So yeah, what your thoughts on the sort of maximum numbers and who would the good staff mix be to do this?
So for the asthmas, asthma nurse, you need one facilitator because you need to have crowd control with the children particularly around. So you need one facilitator and one clinician, and the clinician can be the asthma nurse. We had a pharmacist in as well who could prescribe, which was really handy. But the asthma nurses can give guidance as well. So really just one clinician and one facilitator, because what you're doing is you're putting your time and effort into a 1.5 hour session. So you want to make it worthwhile by being clinician light to make the most out of your appointment use. And normally, in terms of the numbers of children, I would say I think 12 is a bit too many because it gets a bit noisy. So I'd say maximum of 10 really, because you want to make it very personalised, and making sure that everybody's really aware and filling in their care plan. So anything from 6 to 10 probably.
Yeah, absolutely. And it depends a little bit on age as well, doesn't it? And I know just other tips around doing pediatric group clinics. If you do them in school holidays, just be aware that you might have other siblings children coming along, which can increase the numbers. So just be very specific in your joining instructions about whether or not other children are allowed to come as well and that kind of thing. And remember, I guess, with children too, that you can do online, can't you? So you can, because kids are so happy and comfortable online, particularly older children, teenagers. Often they're much more interactive in the chat than they would be in an appointment with a clinician face to face. So think about it's a very much a sort of pick and mix, isn't it, Rupa? Where you can really use this as a tool to create a really person-centered approach.